Welcome everybody to the Implementation Toolkit for Small and Sick Newborn Care webinar. Welcome, please introduce yourself in the chat. Next slide, please. My name is Dr. Mbozo Sipalo. I'm the Knowledge Management Lead for the Newborn Toolkit, primarily focused on the English audience. Welcome to the Newborn Toolkit Joint Learning Community. Our aim of this series is to encourage collaborative learning for faster progress together for small and sick newborn care. Our 2024 webinar series is structured around the WHO UNICEF 10 core components of small and sick newborn care. Today's topic is a very exciting one. Our topic today is on data and dashboards to drive quality improvement on newborn wards. And would like to share that in 2023, the Newborn Toolkit had over 28,000 users from 170 countries. So I'm very grateful and thankful that we have more people coming on board to share this wonderful resource. To join the newborn community and to hear about webinars, news, and to share tools or ideas, please sign up to our Toolkit newsletter. You'll be able to see QR codes on the screen for our newsletter in English, our newsletter in French, and our news, and you can follow us on our social medias on Twitter, LinkedIn, and Facebook. Next slide, please. All right, so today for our webinar, we have our vibrant host, Dr. Alex Stevenson. He's a neonatologist based in Zimbabwe and the president of the African Neonatal Association and the co-PI of the African Neonatal Network. Welcome, Dr. Alex Stevenson, and over to you.
Thank you very much, Mbozo. I'm already speaking too fast. We all have to remember to speak slowly so the translators can keep up with us, which reminds everybody that if you are a French speaker, you can click on the interpretation or translation button, and you can have the conference in the presentation in French. And thank you to everyone who is introducing themselves in the chat. It's always so exciting. We've got so many people from all over the world. So please introduce yourself and tell us where you're coming from. As you heard, today is my special interest, my chiefest soul delight. Data and dashboards. That's what we're talking about today, and we'll get to that in a moment. But of course, we'll be having these seminars every month. Next month, talking about immediate kangaroo mother care and the Omwana publication coming out of Uganda. Following that in June, infrastructure for small and sick newborn care. And later on in June, the humanitarian focus, the French context. So, merci, Lauren.
Bonjour et bienvenue à le webinaire. Veuillez vous introduire dans le chat en indiquer votre nom et votre organisation. Si tu veux écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton affiché en bas de l'écran. Et j'espère que vous nous rejoindrez à notre prochain webinaire. La prochaine webinaire en français, ce sera sur de fournir l'aide à les contextes dans les nouveau-nés pour les crises humanitaires. Merci beaucoup.
Wonderful, thank you. So we are going to have an overview of data dashboards for neonatal care. And then we're going to hear about the very important issue of monitoring and maintaining the quality of your data. And then when we have good, high quality data that we trust, we're going to hear about what you do with that data, because the whole purpose of data is about improving the quality of care that we deliver. And finally, we're going to put it all together and hear about amazing perinatal data systems across Latin America. We very much want questions and discussions. We will be having the questions at the end of the 4 presentations, but request that you put your questions in the chat if you want as we go along, and then we can refer to them when we get the questions, or if you would rather give your question by audio, we'll be having 10 minutes at the end for that. And so, ladies and gentlemen, with no further ado, we'll be starting with our first presentation, which, as I said, was an overview of learning on data and dashboards to transform neonatal care, from the inimitable and wonderful Professor Joy Lorne, our champion-in-chief, who needs no further introduction. Joy, over to you. Thank you.
Thank you, Alex. Thank you, everybody. And Alex, this is your personal passion, and I know I can see many wonderful people who have joined and know that it's your passion too. So I'm going to start with an overview. But before I get into an overview of particularly individual level data and dashboards, I want to flag to all of us this very important data release from WHO and UNICEF just a couple of weeks ago on levels and trends of child mortality. So the good news, with only 5 years or so to go to the Sustainable Development Goal target, is that the 2022 estimates for child deaths, it's fallen below 5 million for the first time. And this is the good news. The bad news for us, and particularly on this webinar where we're thinking about neonatal outcomes, is that the global average neonatal mortality rate is stuck at around 18 for the last 5 years. That the average annual rate of NMR reduction, good news, is increasing in South Asia. It's now at 3.8% per year, but it's actually getting slower in sub-Saharan Africa. But the total number of newborn deaths is stuck again at 2.3 million. This is around 47% of under 5 deaths. And in sub-Saharan Africa, it's been the same number since the year 2000 because of increasing birth cohort and our lack of progress in reduction. So clearly we need to change what we're doing. We want a mortality transition. To do that, we need to get a care transition. And for the care transition, we need different data. So if we look at the world now, this is all 200 countries that are tracked by the UN. The world has changed. There are a few countries with a very high mortality rate, above 45 neonatal mortality rate, so per 1,000 live births. The majority of the world actually is now in this band with neonatal mortality rate between 15 and 30. That's most of South Asia and most of sub-Saharan Africa. That there are fast progressors, particularly in South Asia. Our fastest progressor in Africa is still Malawi at around 2.9% per year. And if you want more information on that, we had a really exciting webinar with Malawi government talking about this in January this year. But if we think about the data and the care, so this is mortality going down, care going up. Now 87% of births are in facilities worldwide. And within that, we still have major quality gaps. But in the care transition, particularly for neonatal mortality, once you get below about 15, you have to have neonatal care with full respiratory support for babies with preterm and other aspects of level 2 neonatal care. So all these fast progressing countries, what they have in common is they have scaled up neonatal care units. But another thing they have in common is they've made a shift to individual neonatal data. So not just an average, like a total number of admissions, a total number of deaths, a total number who get kangaroo mother care. It's individual level data. So you can say which baby had which birth weight, had which care, did they survive? And then you could also link that on to their thriving. So what we need to do to go faster in mortality transition, as well as a care transition, is to have a data transition. So if we look at the data at these different levels, in the higher neonatal mortality rate levels, we still have many births at home. For data, we're reliant on a subset, usually from intermittent household surveys like demographic and health surveys. As we transit into this mortality rate, kind of less than 30 and down to 15, most countries have facility-based aggregate data, classically with DHIS2, which is in about 80 countries. And in these, we have maybe tens of variables on neonatal care, and they're mostly aggregate or averages, pooled data. So total number of deaths, total number with low birth weight. And the transition we need to make is to move to individual level data, where each baby still has that data. It can be linked to the aggregate data, but we need to be able to have which babies had KMC and CPAP, for example, especially as we move towards KMC for less stable babies. And if we look at the lower neonatal mortality level, they have individual level data, often with thousands of variables, and it's linked, for example, forward to be able to follow child survival for thriving and neurodevelopmental outcomes, often over decades. So the transition we want to make, particularly for the highest burden countries, is around here. And so what could we learn from the high income countries that have already made that mortality, care and data transition? Well, here are some examples of quite famous neonatal data sets across specific countries or across regions. And we're very excited to have Dr. Pablo Duran speak to us about this Latin American one, which has been running since the 70s. We're also really excited to have Erica talk to us about Vermont, Oxford, which is one of the most famous high-income country data sets, which require membership and a subscription as well, so a different model for that. So if we look at all of these, what we tend to do is to look at where they are now. So for example, this is the UK data set, which has dashboards that you can split by gestational age, has many different components, and it's kind of dispiriting for us, because if you look at this, this is thousands of individual level variables. Every baby has thousands of data points that they're linked backwards to the mother, they're linked forwards to the child in interoperable data sets. But they didn't start here. So for example, this one started in one hospital with leadership that then spread across the UK. And they started with a smaller number of variables. So how can we learn? So if we look at both the high income countries, and I want to give you one upper middle income country example, India, and one from a low income country, and then say, what can we learn? What are the principles? Where do we start? So India really has an inspiring and ambitious scale up of neonatal care units. So over this time period, which is now about 15 years, they went from 18 special care neonatal units up to now about 940. There's been really substantial government investment at all levels. And one of the things they did early, about 10 years ago, was to hire data clerks. So to design a data set with the data load not being on the neonatal nurses or the doctors, but specifically on a data clerk. That data system is now operational in all of these different units and collects more than 1.2 million newborns per year, with individual level data that is collected from their clinical notes, with around 113 variables during admission, but it's also linked to follow-up data, so very inspiring. And if you look across what has happened in India, during the time period that this care has been scaled up and the data have been scaled up and also are used, they have really increased their average annual rate of change for neonatal mortality rate. So really being able to say which babies are getting which care and which outcomes can really change your care. And then this is the inspirational example from Malawi. So Malawi has 27 districts. They now have 37 newborn care units. And Malawi set out to have an individual level data set that could be operationalized. And the government specifically said that that shouldn't have more than about 50 variables in it. So they have a data set which after each baby is discharged, around 55 individual level variables are entered onto a form, which is then entered into a computer. The data clerks are paid for by the government. And then there's a live facility dashboard, and you'll see some examples from that in the next talk. And this data set is held on DHIS2 servers and is being linked into the aggregate system, but keeping the individual level data. So you can say which babies got CPAP and KMC or were hypothermic on admission. Also trying to look at infections and many other critical aspects for reducing neonatal mortality rate more. So learning from this data transition in high-income countries, some middle-income countries that have managed to do this, and then also from Malawi, 4 principles. First of all, start where you are and start small. Less is more. So particularly in systems where people are struggling with an overload of data collection, picking a few variables and really prioritizing those on coverage and quality that you can change now on a neonatal ward, and particularly for level 2 small and sick newborn care, the highest impact interventions. So within that, the KMC moving to have that more often and earlier, CPAP, respiratory support, hypothermia prevention, and the huge problem we have with infection outbreaks, as well as jaundice management and other key aspects on nutrition, which are fundamental. And then if you start small with a few things, you can always add more. If you move to having some tertiary units with more complex care, you can add in there. If you want to link to other data sets, you can link to the child or to the maternal. And ideally, this would be within, for example, a DHIS2 system. Second learning is that data quality is key from the start. If you have poor quality data, you will have poor quality care and you can't trust it. And so a really important decision here is who collects the data. So if this gets landed on nurses who we don't have enough of, or doctors who we don't have enough of for driving quality of care, it can affect both quality of care and also have poor quality of data. So really critical to think early about having a data clerk, and salute countries that have made the decision to hire data clerks for this purpose. And then there's a lot of learning, which we don't have time to go into now, but you can find more on the toolkit about how to avoid data delays, how to reduce missingness, and then how to increase the efficiency of your flow. If you already have an electronic medical record, can you link direct? If you're using clinical data on paper registers and notes, how to enter that ideally straight into a computer at the time of discharge. And then to be careful about mortality comparisons. So if you penalise hospitals that are doing more complex care, they may, by definition, because they have more complicated babies, have higher mortality rates. And so you'd need to think carefully about how to compare mortality over time and between units. And importantly, the smallest babies may be systematically missed, and so you don't want to penalise hospitals that are doing better at reporting the smaller babies. The third learning is about using data, and we will hear this very much in the rest of the webinar. So regular use, not just up the system, but on the ward, is really foundational to valuing your data, collecting it better, and ways that you can make that accessible, like having dashboards on the ward, having it linked to your daily care. Not just the clinicians involved, but having biomedical engineers, hospital administrators using the data at all levels. So as well as on the ward, there may be things that need to be changed at the hospital administrator level on infrastructure, or above at the national level in HR. And that data capacity is critical. Cannot assume that the data that are being entered or the way they're interpreted will lead to the right decisions. That needs support and mentoring at all stages. And the final learning, I'm going to land on this, is that we need to keep the end in mind. If we really want impact, having one hospital in a country that has a wonderful data set will not lead to national impact. It would be better to have a smaller data set and have it everywhere, like Malawi has chosen to do and like India has done. Often the government will be the most crucial platform in most high burden countries, but there are countries also where private sector is a large proportion, and other ways that licensing can require those countries to report, those facilities to report on certain variables. DHIS2 is a critical partner, and they do have individual level data linkage for other topics. So for example, for COVID or HIV. How can we do that together for neonatal care? And then if it wants to be at scale, we have to be careful to ensure that we're respecting local laws, we're anonymizing, that we're doing all the right things. We can't just rush with the data set without thinking carefully through about data flow and data governance. So we're going to pass on to the other talks, but really what we're excited about here as a community link to the toolkit is how can we go faster together? How could we have comparable individual level data sets that will allow us to benchmark across countries as well as within countries? And we have resources on the toolkit. Please use these, please add yours, please share your ideas, and please can we go faster together? Thank you so much. And I pass back to Alex.
Thank you so much, Joy, for that excellent presentation and emphasizing the power of individual data, of reminding us that we start where we are, but we keep the end in mind. So as promised, we're now going to have a presentation from Nebiu Wendwessen, who's going to tell us about improving the quality dashboards in 4 countries with NEST 360. And Nebiu is an improvement advisor and possesses a diverse background in nursing, public health, and healthcare quality management. With 17 years of experience in the health sector, currently serves as the quality improvement advisor for the NEST 360 program. So thank you very much.
Thank you very much, Alex, and hello, everyone. I'll talk about more NEST 360 experience in using dashboard for improvement in quality. So NEST 360 is our alliance of 22 organizations, and among these 22 organizations, 70 of the organizations are belong in Africa. So currently we are working with 5 African countries to meet SDG 3.2 goal for newborn survival. So currently we are working with Malawi, Kenya, Tanzania, Nigeria, and Ethiopia to support 134 hospitals. And these 134 hospitals, the hospitals, conducting more than 1 million delivery per year and admitting more than 200,000 newborn admission per year. So our intention is to leverage the importance of data for improving quality by having a comparable data set across multiple countries and up to multiple level of program implementation. And also we want to improve the data use at the ward level and hospital management and government level. So by having this dashboard, we plan to have multiple country learning systems. So for our dashboard designing, we do have input from neonatal inpatient dataset. This neonatal inpatient dataset have different components starting from the admission and mortality data. And this admission and mortality data, we record admission and by disaggregating inborn and outborn, and we also collect data on the length of data and the primary diagnosis for admission. The other component of this data is mortality trend in terms of neonatal mortality rate and the cause of death by diagnosis and birth weight. We also collect clinical data like coverage and quality data. So in this clinical data, mostly we'll focus on the vital sign during admission and high impact intervention like CPAP initiation, chemistry, coverage and quality, infection treatment and management. Also, we collect data on jaundice management. To support in the government level or leadership level decision making, we collect system data like human resource number mix ratios. Also, we collect data on the device functionality and consumable for using those devices. On the other aspect of our data is collecting data in terms of outreach, and it's related to the importance of infrastructure for improving quality. So this neonatal inpatient data set help us to design NEST dashboard. This is a kind of quality improvement dashboard with better data visualization like control chart and run chart. So it helps us to look data individual facility level, country, sub-national level, multi-country and program level for improving quality. Next, please. So this nested dashboard have different content by section. The first section is about the overview of the dashboard. It tells about installation data and coaching, QI coaching related issues. The other section is admission and mortality data. And mostly we are focusing on the clinical coverage data that mainly deal with the quality of CPAP, quality and coverage of CPAP, jaundice, prevention and management, hypothermia, infection, vital sign monitoring, and care nurses. So the other segment will focus on the inputs like device and supplies, device functionality, stock out of consumables. Also, we look for infrastructures, human resource, and data quality in terms of data delays and data completeness. Next slide. So what's the importance of the dashboard? This dashboard used for data for action at different level of our support. The first level of support is like facility level. At the facility level, as you can see from the picture, the facility ward improvement team and quality improvement team use this dashboard for identifying quality gaps and designing quality-related and improvement interventions like change ideas, and they use the dashboard to look whether they are progressing to the positive directions of their AM statement. So from this picture, you can see that the storyboard from different country and different facility, they are documenting their PDSA and they are following the implementation of their PDSA and the impact of this PDSA using nested dashboard in each ward improvement team members. Next slide. So the other level of data for action is country and subnational level. At the country and subnational level, they use nested dashboard to make informed decision making in terms of infrastructure like power outage and human resources, availability and the requirement of device and consumables. So recently we learned from different countries they are using this dashboard to determine the important and the required resources for improving the quality of newborn care at each facility level. Next slide, please. So the other level of learning data utilization for action is multi-country level. At an team, we do have, every 3 months multi-country QI learning platform. Then we call it pause, reflect, and act meeting. And this meeting, we learn from successful and unsuccessful QI projects. And we learning across each countries and different, in this meeting, different participants will be involved from government, from NEST program implementer, from the facility. So by that, we focus on topics like hypothermia reduction, management, and prevention. Also, we talk about care must increase coverage and quality. Recently, we are focusing on CPAP coverage improvement. And during that discussion, we use a quality improvement approach and methodology to discuss about our learning and better interventions. So from this picture, you can see that one of the presentation for reduction of hypothermia in one of the facility. And in the picture below, we see we can use the nested dashboard as annotated run chart to see whether there is impact due to the intervention proposed by the ward improvement team and that's country team members. Thank you very much. This is all from me, and I welcome any suggestion, question, ideas. Thank you, Alex. Back to you.
Wow, wonderful. Thank you, Nebil, for that fascinating presentation of the use of your quality dashboards in the NEST 360. I mean, it was fascinating to actually look in at some of your pictures and see what was actually going on the ground. So well done to you and well done to all of your teams. As I mentioned, the questions we'll be doing at the end, but please feel free to put questions in the chat as we go along. As I think Nebios introduced the next topic quite well, talking about data for action. So our next presentation is from my mentor and friend, Erica Edwards from the Vermont Oxford Network, who will be presenting on neonatal quality of care dashboards. Thank you very much, Erica.
Thank you, Alex. So to start, next slide, please, Joy. Vermont Oxford Network is a worldwide community with over 1,400 members in 38 countries, high, middle, and low-income countries, dedicated to ensuring that every newborn and family achieves their fullest potential. Next slide. With funding from the Bill and Melinda Gates Foundation, in partnership with the African Neonatal Association, we started the African Neonatal Network in 2023. The ANN is a quality improvement and leadership development collaborative of 17 hospitals in Ethiopia, Nigeria, Rwanda, Uganda, and Zimbabwe. The foundation of the ANN is high-quality data collection using a one-page form. Next. Data are used in quality improvement for many reasons, including information gathering or establishing a baseline before you start a project, benchmarking yourself against yourself or yourself against peers, and evaluating data quality. Next. Data collected can be used to create a SMART aim, one that is specific, measurable, achievable, relevant, and time-bound. Next slide. And that SMART aim can then be tested as part of a Plan, Do, Study, Act cycle in an iterative quality improvement initiative. Data are used during the plan phase to set improvement goals, as part of the do phase to see how the test of change is progressing, during the study phase to assess the final outcome of the test, and as part of the act phase as evidence to continue or abandon the test. I'll walk through an example now, and I want you to know that all of the data in this presentation are anonymized. None came directly from a member hospital. In 2023, a review of the data showed low use of immediate kangaroo mother care at this hospital. And these slides also, some of the images from all of the images of the charts and tables in these slides come from Vermont Oxford Network reporting. Next slide. When doing information gathering for quality improvement, it may be important to stratify on certain infant characteristics that may drive differential risk, such as birth weight or gestational age. Stratification by birth weight in our population found that rates of kangaroo mother care were low across the gestational ages, but particularly among infants weighing less than 2,500 grams. Next slide. Additional filters to narrow the population can also become important. Immediate KMC is most important among inborn infants, and filtering on birth location showed that the infants who could most benefit from this intervention were not receiving it. Next slide. So we created these data, we used these data to create a SMART aim to increase the proportion of inborn infants receiving immediate kangaroo mother care by a relative increase of 50%, from 4% to 8%, by the end of 2024, by opening an immediate KMC unit in order to improve overall infant outcomes and reduce neonatal mortality. We were able to use the data to start a run chart in the first 3 months of 2024. We added our goal line of 8%. Run charts are a foundation of quality improvement because they allow you to view your data over time as you implement PDSA cycles. We will continue to monitor our progress monthly, but we can also look at these data by week as we implement other PDSA cycles to see if the trends by week are informative. Switching gears, we were also interested in looking at admission hypothermia among inborn infants, since admission hypothermia and immediate KMC go hand in hand. Looking at our data on an annual basis over time, we saw that we had what looked like lower rates of hypothermia in 2023, which was surprising to us given our low rates of immediate kangaroo mother care. We looked at the data monthly and added a calculated median. Next slide. The median line plays an important role in run charts. There are some simple rules for interpreting run charts. I've put a link to a one-page description on this slide. A shift is 6 or more consecutive points, either all above or all below the median. A trend is 5 or more consecutive points, all going up or all going down. And we had neither of those. We do have an astronomical point over at January 2019 and some blank areas in 2023. Next slide. So when we looked at the data for those blank areas, we learned that in 2 of the months, there were no eligible infants, but in 1 of the months, there was no data. It's important to look at the data that comprises the chart, not just look at the image. And dashboards can therefore be helpful to drill down into the data that and to assess data quality. Next slide. Dashboards can also be used to benchmark your center against your peers. For benchmarking, we sort the hospital level rates for each measure from highest to lowest. And we report the hospital level rates at the median, as well as the rates at the 25th percentile or Q1 and the 75th percentile or Q3. In this example, half of centers use delivery room CPAP with at least 11.8% of infants, and 25% of centers use delivery room CPAP with 26.3% of infants or more. Our center had a rate of 61.7%, putting them in the Q3, or the highest proportion of centers using delivery room CPAP. Next. These relationships are also shown visually using box plots, where the dot is the center rate, the line represents the hospital level median, and the box represents the 25th and 75th percentiles. Next slide. So in conclusion, data from neonatal dashboards used for information gathering, benchmarking, and improving data quality are the foundation of quality improvement to help create smart aims and design PDSA cycles for high impact QI. Thank you.
Thank you, Erica, thank you so much, because that is what it's about. We don't collect data for data's sake, but we collect data to improve the care that we give, and those are the tried and trusted quality improvement principles. And also, of course, it's always very interesting to see benchmarking and how we can use that to self-assess what our priorities are. So thank you, Erica, and good luck with your IKMC unit. Next and last to speak, putting it all together, is Dr. Pablo Duran, who is affiliated with the Pan American Health Organization, WHO, as a regional advisor. He's a medical doctor, a pediatrician, and an epidemiologist, and holds an MD, MPH, and PhD. Over to you, Pablo. Thank you.
Thank you, Alex, for the introduction, and good afternoon, good evening, and good morning, everyone. I'd like also to thank the organizers for inviting us to share the data and the perspective from the perinatal information systems in Latin America and the Caribbean, to the presenters who preceded me, and to all of you. Next slide, please. So we do not have doubt about the importance of having data and information for decision making, but advocacy and work in this sense in today's societies, information societies, will never be insufficient. In the case of Latin America and the Caribbean, and mainly focusing on perinatal health, we face different situations and challenges. Firstly, I'd like to highlight important inequalities between countries and within them that are in our region. Inequalities according to ethnicity, gender, place of residence. It gives us a relative gap in the neonatal mortality rate in the Americas, that a value of approximately 9, with extreme values of 3 to 3 to 27 neonatal deaths per 1,000 live births. So this is an important challenge. And the next one, please. So secondly, I would like to highlight the trend recorded in neonatal mortality, which is downward, and in regional terms, the achievement of the established goals is expected, although with a high proportion of deaths from preventable causes. So the next one, please. So in contrast, birth in health facilities are on average greater than 95% in the region, and this is why quality of care and the provision of essential care to newborns is critical to achieving the improvements in outcomes. So based on the digital transformation in the region, the Latin American Center for Perinatology and PAHO has developed since 1970 the information perinatal system known as SIP, which is a standardized clinical record focused on reproductive, maternal, and newborn health. It also represents a standard of care, guiding healthcare providers to a standard of care, serving as a guide for the provision of care, while also providing alerts and notifications about inadequacies that require special attention. The perinatal information system includes a perinatal clinical record that allows the users to record preconception, prenatal, labor, delivery, and postnatal information about the mother and the newborn, and two specific, the next one, please. And two specific forms, one for healthy newborns and the other one for small and sick newborns. You can see here the significant number of countries using the system as a national standard, either on a paper-based or an online format with different degrees of coverage. The next one, please. As I already mentioned, the perinatal clinical record, the one on the left, shows not only the form, but you can see the yellow circles that identify risk or critical conditions to be identified for the practitioners. As I mentioned, the specific component of the newborn within the perinatal record collects information about the characteristics of the newborn, the person attending childbirth and newborn, Apgar, anthropometry, specific interventions as time at core clamping or immediate skin-to-skin contact, the condition of referral to NICU, newborn screening, conditions at discharge. But you can see that there are several other forms related to maternal health, maternal near miss, birth defects, specific conditions as Zika or dengue or chikungunya, violence against the woman, and a specific component for newborns at NICUs. And in that form, again, characteristics at admission, special care, diagnosis, treatment related to respiratory support, sepsis, surgery, growth and nutrition, screening, newborn screening, health promotion or other conditions and discharge, and mainly follow-up after discharge are collected there. At the same time, the system includes a perinatal card that belongs to the mother and to the family to have all the information for the newborn. Then the next one, please. Oh, I think there's one missing. But for all these modules, the perinatal clinical record represents not only the basis for collecting the data, but also provides automatic reports that provide information consolidated linked to basic statistics or other maternal and newborn outcomes. Automatic reports in newborns are grouped into perinatal outcomes, quality of care by coverage of essential interventions, and conditions at the time of discharge. In all of them, the outcome and the automatic reports provide the assessment of inequalities that can be accessed in an immediate click on the report menu, and the automatic reports are available. So, finalizing my presentation, the perinatal information system was designed in order to provide a useful tool for different purposes. In terms of management, the SIP centralizes all medical records related to women pregnant, women and newborns in a real time, allowing in-depth knowledge for the institutional and clinical operation. Also, the effectiveness is important in terms of it allows adequate and timely decision-making for problem solving, providing alerts, and guiding the clinical provision of care. In terms of specificity, even when there's a regional model, there are also country models that can be personalized and PAHO tailored for local requirements, specific forms, and adapts the system to national and institutional needs. In terms of communication, it allows to improve the coordination between the policy making, the managerial at the health facility level, and the clinical provision of care. It guarantees equity in terms of providing information, highlighting the most vulnerable population, and it's free of charge as the perinatal information system is developed and maintained by PAHO, free of charge for all the users. It's available in the 4 languages, official languages in the region: Spanish, French, English, and Portuguese. And it's regularly updated based on the best available scientific evidence. And finally, the system is interoperates with other information systems, so it can be linked to other information systems at health facilities or countries. The next one, please. E-mobile version is almost ready to be launched in order to allow also the use of this information on the cell phones for the healthcare providers, but also for the patients. And I'd like to mention at the end that we have also launched a specific app on neonatal health called eCBB that provides specific information on newborn health, IMAT, health teams, and facilities. And it's also available in the 4 languages, official languages in the region. So the system instructions and the system itself is available at www.sippplus.org, and it's available for free. So thank you very much for your attention, and I'm open to answering your questions. Thank you.
Oh, my word, that I want that. I want that SIP Plus. I think I'm going to have to go and live in the Caribbean. That the standardization, I love that it standardized the healthcare record, but also set the standards of care. That it was although it was standard, like I'm sure it has a minimum basic standard set, that it is customizable according to a country or an institution's needs. The interoperability with different data systems is so important. And as if that isn't enough, now there is an e-mobile version in 4 countries. I mean, that is where we need to be going. Thank you so much. I'll certainly, in case I haven't got it across, I'm really excited about that. And I didn't even know about it until 10 minutes ago. So thank you so much, Pablo. That's really inspiring. And we so desperately need that in Africa. I'm sure other regions, like, I mean, India's already, as we heard, well on their way. But I think many other regions could and will learn a lot. Right. Ladies and gentlemen, the questions have been coming through. There have been some in the chat, but we're also supposed to put them in the Q&A. So let's start with the Q&A, and then I'll look for the ones in the chat. Here's the first one that's coming in front of me from Indira Narayanan, who was saying, great and relevant presentations, and she's unable to access the Brazilian health policy. I think if anyone could write the link in the chat or any suggestions, that would be popular. Colleen Thomas is also asking for the SIP Plus link. Yes, I was also writing that down. I got sipplus.org, but if someone definitively has that, please put that in the link because I think people will want that. Some of these questions have been answered as we've been going about how many hospitals NEST 360 is covering. That's been answered. 67 hospitals, and in phase 2, the number will be 134 hospitals. That is no mean feat. Well done to our brothers and sisters and comrades in arms at NEST 360. Very interesting question from Ashiru. And this is one of the inspiring things about these seminars, is how much we learn. And I think this question needs to be answered by Ashiru, if possible, who was saying that from their work in Kano in Nigeria, they understood that facility level discussions and performance improvement is the most impactful level that drives improvement, and asking about what our learning on that is. But noticing that beyond the PSDA cycle, a new one, the DIVA, the diagnose, investigate, verify, and adjust process, also proves to be effective strategy to discuss data and chart improvements in our services. I don't know, Mbozo, if it's possible to give the mic to Ashiru to talk to us, because I'm very interested to learn more about this DIVA process. If that's not possible, maybe someone else.
It's a little tricky to do that, but maybe he can post more, and maybe
sure.
Maybe Erica can also answer a little bit more, because sometimes we get so many different acronyms, but sometimes it's the underlying principles that matter even more than the
So Ashiru, please feel free to share your learnings in the chat or the Q&A, but in the meantime, I'll pass that question over to Erica.
No, I have to admit that DIVA is new to me, but I agree with Joy that frequently the underlying process is the same. I think perhaps with DIVA, it sounds like it's less like going out and starting a quality improvement initiative and more like using your data to understand the underlying issues and verifying them, as we've said, like with data quality and adjusting what you need to do to get better quality data. So it's similar to a PDSA cycle in that you're still using the data, but a PDSA cycle may be more action oriented as it relates to a quality improvement intervention.
Thanks.
Can I add more?
Yes.
Can I add more?
Of course.
Yeah, in quality improvement, we do have in the globe, we do have different models, starting from model for improvement, Kaizen, Six Sigma, Lean, Total Quality Management. So all the principles are similar, whether we are using DIVA or PDSA, the principle, the background principle is similar. Model for improvement designed from total quality management. So when they design model for improvement, they are particularly focused this model for healthcare setting. It is well tested in the different healthcare testing, but in different conditions, especially the quality improvement practice focus on performance improvement, system improvement. We can use Kaizen, Six Sigma or Lean Six Sigma. So it doesn't matter whether we are using different model or not. The ultimate goal is improving, the quality of care using the principles of continuous quality improvement. So the principle is similar. It has 5 principles. So don't worry about the model, but focus on the how to improve and develop a change idea that could bring improvement and that could change the system toward this better position. Thank you.
Thank you. There was a question in the chat rather than the Q&A that I saw earlier that interested me because it's a problem. And it's about the legalities and standardization of sharing data and the problems of having different countries with different laws, having different requirements. So I might, if the question came to me for the ANN, I would just say it's a problem and we're trying to deal with it country by country, but you have to respect the laws of the countries where you operate, but it can become very time consuming and it can completely stop data sharing. For instance, at my hospital, I'm unable to share any data. So I would like to ask Pablo about the experience in South America and the Caribbean of what problems you've had in terms of different countries' laws on data sharing and how you've overcome them.
Thank you, Alex. And it is a really important question. And in fact, we as PAHO do not keep the data. So data is recorded in servers located at country level. So the data is kept at the country or the institution level, but not shared with other instances out of the country. So we are very serious about keeping the confidentiality of the information. So it's not possible to access the data from externally from the institutions or the country. And in fact, the system has a strong security perspective in terms to avoid accessing information. So this is something important that we keep in mind, and we work on that all the time.
Thank you. I am learning a lot from South America today. Joy Lon, your experience in Africa or your advice?
Yeah, I mean, to build on what Pablo has said, I think you need an explicit data sharing agreement with all the different partners, including government and other partners. We do this across NEST. I'm happy to share that in more detail another time if that's helpful. But I think the fourth principle I gave about keeping the end in mind, you want government to own the data and you want it to be used. And so the critical thing is that the data are still owned at each facility, owned by the government, anonymized, and you're explicit around who has access so that you're making that possible for the government to be part of the system and lead it. Because it's so important that we really ensure that the whole country, all different facilities can be linked. If it's just one or two teaching hospitals or on a paid subscription, you're not going to have the impact that's needed. So I really salute Pablo and the team at SIP. When I was at CDC in the 90s, I learned a lot from SIP. But I think what we need to do is start where we're at and move forward and keep the end in mind. And we need to keep that as a critical part of our thinking, and also recognize that DHIS too manage that, and there are ways to link with them to do that. And that's a really critical part of a pathway in many countries. Thank you.
Thank you, Joy.
Alex, can I just jump in for a
Of
second?
course.
Though Joey would say that we also need to start where we are, as you pointed out at the beginning of your presentation. And for the members of Vermont Oxford Network, all of them are hospital level, facility level members that sometimes work with the government and sometimes don't, but are still managing to make remarkable improvements, many of them on a countrywide level, in care. So I think that we can get really caught up in trying to get permission from governments, and we have managed to build a pretty successful network just with boots on the ground. So again, start where you are. I think that's really the most important thing that we can take away from this.
Start where you are, keep your eyes on the goal, learn from what other people are doing. I mean, wow, SIP is going to be a wonderful resource, and accept the reality that it's 3:01, at least in Zimbabwe, and there are so many amazing questions coming through, which is a tribute to the webinar that we've had today of people's interests. But unfortunately, time is not on our side. It behoves me to thank everybody, especially the toolkit, which you can access, and I highly recommend that you do access to see all the resources that are on the toolkit. To thank Mbozu, as always, who does all the hard work putting this together, to Lauren and the French translators. I did remember at the beginning to speak French, and now to speak slowly, at the end to speak slowly. And of course, to all of you, the amazing people who are actually in the trenches and doing the work, collecting the data, diligently submitting it. Thank you so much, ladies and gentlemen, mesdames and messieurs. This has been the Newborn Toolkit Seminar Series, and we will see you next month, to talk about the Omwana trial and kangaroo care before stabilization. Thank you so very much.